Hello everyone, welcome back to the series of lectures in nephrology. In the last class, we have learnt about the basics of fluid management and the basics of total body water and so on. So in today's session, we will be learning about some electrolyte imbalances. So the first and the most important electrolyte that we should be understanding is your sodium. So in today's session, we will be learning about the disorders of sodium. Okay, so we'll start off first with hyponatremia. So, to understand hyponatremia, let us understand what is the normal sodium levels. So, the normal sodium levels is anywhere between 135 to 145 milliequivalents per liter. Okay. So, what is hyponatremia? Hyponatremia is any level less than 135. Okay. So, always remember that whenever you have hyponatremia, it also means that there is some amount of hypoosmolality. We know that the normal serum osmolality, as we have learnt in the last class, is between 280 to 290 milliosmoles per liter. So, whenever there is hyponatremia, that means that there is some amount of hypoosmolality. That means the osmolality and the sodium go hand in hand. Okay. So, what is this concept of pseudohyponatremia? What is this concept of pseudohyponatremia? So, pseudohyponatremia happens when the osmolality is increased. When is the osmolality increased? For example, in hyperglycemia. So, that means that the osmolality is increased because of more sugar in the blood, right? So, in hyperglycemia, you can have a hyponatremia, but in the hyponatremia that occurs associated with hyperglycemia, the actual sodium is not the sodium which is denoted by the lab value. Okay. So, what happens is that for every 100 milligram per deciliter that there is a rise in the glucose value or the serum glucose value, the sodium levels can change by 2.6. Sodium levels can change by 2.6. So, that is the reason why you should be aware of the actual sodium value. So, when this is usually seen in your management of diabetic ketoacidosis. So, when it comes to diabetic ketoacidosis, you see that whenever the sugars are more than 400, 500, there will be some amount of associated hyponatremia. So, do you go ahead and treat that hyponatremia? No. You bring down the sugars, you bring the sugars under control and then check for the sodium reports. Okay, fine. In the presence of normal osmolality, now the osmolality is normal, can you have pseudohyponatremia? Yes, you can have pseudohyponatremia, and this happens in the presence of hyperleukocytosis. This happens in the presence of hyperleukocytosis. So, why does this happen? Whenever there is hyperleukocytosis, what are we measuring? We are measuring the plasma sodium. So, when there is hyperleukocytosis, the percentage of plasma is lesser. So, the plasma sodium also appears to be less when you do a laboratory testing for the same. Okay. So, that is about your concept of pseudohyponatremia. Fine. Now, let's move ahead. Okay. So, now let's move ahead. Now, we are learning about your approach to hyponatremia. So, what is your approach? Okay. So, the first step in any patient who presents with hyponatremia is your volume status assessment. So, how do you do that? What all do you check for when you do a volume status assessment? You look for the presence of pedal edema, right? You see if there is pedal edema. If the patient has pedal edema, then that means what? He is in volume overload. Then you look for the jugular venous pressure. If there is jugular venous distension, that means what? Again, it means that he has a higher volume, effective circulating volume. He has a higher effective circulating volume. Okay. Apart from this, you look for bibasal crackles or bibasal crepitations. Right. So, this is how you do a volume status examination, and once you have done your volume status examination, you decide whether this is a hypovolemia, euvolemic state, or a hypervolemic state. Okay. Now, hypovolemia means what? In hypovolemia, the total body water is decreased and the total body sodium is also decreased. Okay. So, where do you see this? Where do you see this? This basically means that the patient is what? The patient is dehydrated. The patient is dehydrated. This basically means that the patient is dehydrated. Okay. So after this, what do you look for? You look for where has the loss of water happened from. Is it from the kidneys or is it from the extrarenal loss? So whenever there is loss of sodium from the kidneys, naturally the urine sodium will be more than 20. Right. So if the loss is from the kidneys, naturally the urine sodium, UNA is urine sodium will be more than 20. Right. So this can happen in the presence of renal losses, for example, diuretic excess. We know that from your basic pharmacology, diuretics are basically those drugs which help in removal of water and sodium from the body. Right? They are used in the management of heart failure. Correct? So we know that there are loop diuretics, thiazide diuretics. So whenever a patient is on diuretic, you always monitor the dose properly. We monitor the dose, we monitor the volume status, you monitor the sodium, because this can result in your hyponatremia. Okay, so the entire mechanism of diuretics is that it causes excretion of sodium and water. So what happens to the urine sodium? The urine sodium will be more than 20. Okay. Then mineralocorticoid deficiency. Mineralocorticoid deficiency. What is your mineralocorticoid? It is your aldosterone. Now if you go back to the previous lecture and you see your basics of fluid and electrolyte balance, we have spoken about volume regulation, right? So the main volume regulation is brought about by your renin-angiotensin-aldosterone system. So aldosterone is responsible for reabsorption of sodium and water and excretion of potassium by the kidney. Okay. So when the aldosterone is deficient, what happens? There is no reabsorption of sodium and water gets excreted. So mineralocorticoid deficiency results in a hyponatremia. Okay. Apart from that, certain other conditions that you should be knowing is your osmotic diuresis and your cerebral salt wasting syndrome. We will be coming to this cerebral salt wasting syndrome in a bit. So in osmotic diuresis, what happens is that there are certain osmotic substances which are given which can cause diuresis. Okay, so along with the high osmosis, the sodium is also removed. So this is about your hypovolemic hyponatremia. Then urine sodium less than 20 means what? It can be an extrarenal loss. It is an extrarenal loss. Where else can you lose water? This is very easy to understand. If you have diarrhea, if you have vomiting, if you have excessive sweating, you have burns, you can have hyponatremia. Okay, so burns, pancreatitis, vomiting, diarrhea, third space loss of fluids which is seen in your burns and pancreatitis. Okay, so we've understood this bucket. This is about your hypovolemic hyponatremia. So till here you have understood, you have done a volume status examination in a patient who has come to you with hyponatremia. You find out he is hypovolemic, then you do a urine sodium and see whether this is a renal loss or an extrarenal loss. Okay, fine. Then euvolemic means that there is no edema. Then in euvolemic, what all you have to do? You have to remember three main conditions which are associated with euvolemic hyponatremia. You have to remember three main conditions which are associated with euvolemic hyponatremia. Always remember glucocorticoid or adrenal insufficiency. Adrenal insufficiency is your first cause. Second cause is your hypothyroidism and the third cause is your SIAD. What is SIAD? SIAD is nothing but your syndrome of inappropriate antidiuretic hormone secretion. Okay, so in your euvolemic hyponatremia, if the patient is euvolemic, you have ruled out hypovolemic hyponatremia. Then if the patient is euvolemic, what are the three main things you have to think of? You have to think of hypothyroidism, you will have to think of adrenal insufficiency, you have to think of SIADH. Okay, so what is SIADH? SIADH stands for syndrome of inappropriate antidiuretic hormone secretion. So what happens in this? There is inappropriate ADH. As the name suggests, what is the function of ADH? We have learnt it in your volume regulation and osmoregulation as well. ADH basically means antidiuretic. It prevents diuresis. If the ADH is more in SIAD, what happens is that there is volume retention. If there is volume retention, there is an apparent dilutional hyponatremia. There is an apparent dilutional hyponatremia. However, the volume status is maintained. We will be looking at SIAD more in detail. Just understand that in SIAD, the ADH is more. That means that the more water is retained and there is an apparent dilutional hyponatremia. Okay, fine. Now we will look at hypervolemia. What happens in hypervolemia, that means that there is perial edema, elevated JVP, bibasal crepitations, you again look for whether this is renal cause or a non-renal cause. Urine sodium again more than 20, then this is a renal cause. If the urine sodium is less than 20, think of nephrotic syndrome, cirrhosis or cardiac failure. So liver failure, heart failure, renal failure, all of them can cause fluid and water retention. Okay, fine. Now, what happens to the ADH in this? In SIADH, the ADH is elevated, right? So in SIADH, the ADH is elevated. Okay, and what happens to the ADH in hypovolemia? Here also it is elevated, but here this is an appropriate elevation. Why? Because the patient is hypovolemic, he is losing his volume status from somewhere, he is losing water and sodium from somewhere. Then the ADH has to act and it has to retain the fluid, right? So there is ADH elevation, but this is an appropriate ADH elevation. But in euvolemic hyponatremia, after ruling out hypothyroidism and adrenal insufficiency, always think of SIAD. Okay, fine. So this is about your approach to hyponatremia. Oh, now let's move ahead. We will be looking at what is this SIADH. Okay, so what do you think is the type of hyponatremia? We have just now seen this is a hypotonic. This is a, what do you think is the type of hyponatremia? So this is a hypotonic hyponatremia, but it is a euvolemic hyponatremia. Hypotonic but euvolemic hyponatremia. What happens to the urine sodium? The urine sodium is more than 20. Okay, and the urine osmolality is more than 100. So always remember that in SIADH, it is a euvolemic hyponatremia, but it's hypotonic. That means the serum osmolality is low, urine osmolality is high, it is more than 100 and urine sodium is more than 20. So if the ADH is acting, ADH is retaining the water, then why is the patient euvolemic, right? So why is the patient euvolemic? That is because we know that volume system, volume regulation is brought about by the renin-angiotensin-aldosterone system, right? So volume regulation is brought about by the RAS system. So the RAS system is active. If the RAS system is active, then what happens? It is not going to retain your sodium and water, it's going to start excreting it, right? So it is going to counter the ADH. That is the reason why they do not go into hypervolemia, but they have an apparent volume excess because of the SIADH, and they can have hyponatremia, which is more of a dilutional hyponatremia. Okay, so this is about your diagnostic criteria for SIAD. So what is the basic thing? The basic thing that you have to remember here is that ADH is more. ADH is anti-diuretic hormone. So if SIAD, what happens? The ADH is elevated. Now if the ADH is elevated, what happens? There is no diuresis. That means what? There is some amount of water retention. If the water is retained as compared to the sodium, this is going to cause some amount of dilutional hyponatremia. Okay, so this is clear till here. So what are the diagnostic criteria? Euvolemic hyponatremia, there is no edema, neither is the patient dehydrated, urine sodium is more than 20, urine osmolality is elevated. Okay, fine. Now let us look into the causes of SIAD. Always remember that there are a huge number of causes, but one thing that you have to remember is that do not jump to SIADH. Always rule out. There are certain conditions which you have to rule out in a euvolemic hyponatremia. I have already told you that always rule out adrenal insufficiency and hypothyroidism. Right? So always rule out adrenal insufficiency and hypothyroidism before labeling someone as SIADH. Okay? So let us look at the causes. So first thing that you have to know is your malignant diseases, right? So carcinoma, lung, small cell carcinoma, any carcinoma anywhere, including solid organ malignancies like stomach, duodenum, pancreas, GU tract, lymphomas, right? So malignancies is on the top, especially in an elderly individual, persistent hyponatremia. he is not on any drugs that cause hyponatremia, we have ruled out all the other causes, then SIAD, think of malignancy. Then SIAD can be seen even in pulmonary disorders like including a bacterial pneumonia. So bacterial viral pneumonias, TBs, cystic fibrosis and respiratory failure. Okay. Disorders of the central nervous system. So whenever there is an infection of the central nervous system like encephalitis, meningitis, brain abscess, right? Apart from that, any kind of trauma, subarachnoid hemorrhage, any kind of a stroke, cerebrovascular accidents, and other conditions include certain demyelinating disorders like MS, GBS, right? And acute intermittent porphyria. Okay. Very, very important, always remember the drugs. So whenever a patient presents with hyponatremia, please go through the drug list very, very carefully. For example, one of the most common drugs which causes hyponatremia in a hypertensive patient, it is your hydrochlorothiazide, because it is a thiazide diuretic. Hydrochlorothiazide can cause hyponatremia. So what is the treatment for that? You stop the offending drug. Similarly, in a patient of some psychiatric illness, maybe like schizophrenia, if he is been on antipsychotics, if he is been on SSRIs or tricyclic antidepressants and presents with hyponatremia, always look at the drug list and try and stop the offending drug. Okay, let us look at some of the drugs, right? So drugs that stimulate the release of ADH or enhance its actions like SSRIs, TCA, carbamazepine. Where is carbamazepine used? Frequently, carbamazepine is used as an anticonvulsant. Carbamazepine is also used in your trigeminal neuralgia. Okay. Then, anti-cancer drug vincristine, some other antipsychotics. Then, ifosfamide, cyclophosphamide. Again, this is an anti-cancer drug. It is also used in a lot of other autoimmune and rheumatological disorders like SLE and so on. Then, think of desmopressin, oxytocin. Okay. So, this is about your drug list. Other causes are pretty rare, including hereditary or idiopathic causes. Okay. So whenever you see a hyponatremia patient, if you are thinking of SIADH, always try and remember these causes. Always think of the drugs, think of malignancy, and then see whether patient is in sepsis, patient has infection, pneumonia, any central nervous system infection, and so on and so forth. Right? And always rule out adrenal insufficiency and hypothyroidism before you make a diagnosis of SIADH. Alright? Clear till here? Fine. Now let's move ahead. Fine. Now, we had already come across this term of cerebral salt wasting syndrome. Right? So when we were seeing under the approach to hyponatremia under hypovolemic hyponatremia, we had seen this term cerebral salt wasting syndrome. Right? So what is the cerebral salt wasting syndrome and how do you differentiate it from SIAD? Right? So cerebral salt wasting syndrome, as the name suggests, basically refers to the salt wasting that occurs secondary to some kind of a cerebral issue. It can be because of trauma, it can be because of any infection, it can be because of maybe a subarachnoid hemorrhage, right? So that is your cerebral salt wasting syndrome. Now both of them cause hyponatremia, right? So how do you differentiate? So what is in common to SIAD and cerebral salt wasting? Both of them have hyponatremia. Both of them have a reduced serum osmolality. Both of them have an increased urine osmolality. And the serum uric acid, UA is uric acid. Uric acid is reduced in both, right? So how do you know, and even why should you even know whether this is cerebral salt wasting or SIADH? Because the management of SIAD and the management of cerebral salt wasting is completely different. Okay. Now, how do you differentiate these two? SIADH, a patient with SIAD, we have already learnt they are euvolemic, right? So they are euvolemic. Cerebral salt wasting, they are hypovolemic. Hypovolemic means what? They are dehydrated. Okay, so they are dehydrated. If you look at their tongue, it will be parched, it will be dry. If you look at the pulse rate, they will be having tachycardia because of hypovolemia. Okay, so the eyes can be sunken and so on and so forth. So this is how you assess for your volume status, and how volume status examination is very important to differentiate your SIAD and cerebral salt wasting. So cerebral salt wasting will be dehydrated. What about the urine output? In SIADH, it is reduced. In cerebral salt wasting, it is increased. Okay, what about the BNP levels? The BNP levels are usually normal in SIAD. BNP levels is your brain natriuretic peptide, it can be increased in your cerebral salt wasting. Hydration is normal in SIAD, in cerebral salt wasting it is reduced. What about the treatment? When it comes to the treatment of SIADH, the first line treatment of SIADH is actually restriction of fluid intake. Restriction of fluid intake. So always remember, the first line treatment for SIAD is restriction of fluid intake. In cerebral salt wasting, on the other hand, in a stark contrast, you have to administer IV fluids. You have to administer IV fluids, and administration of IV fluids can improve the sodium because they are dehydrated. Okay. So this is a very important concept about the differences between your SIAD and cerebral salt wasting syndrome. Fine. Let's move ahead. Fine. So till now what have we learned? We have learned about what is hyponatremia, we have learned what is pseudohyponatremia, how do you approach hyponatremia, what are the causes for SIADH, and what is the difference between SIAD and cerebral salt wasting. Right. So now let us look at the clinical features. Now, hyponatremia can be classified as acute and chronic hyponatremia. So hyponatremia can be classified as acute and chronic hyponatremia. So acute hyponatremia happens when the sodium levels drop precipitously. So acute hyponatremia is a hyponatremia that occurs less than 48 hours. Chronic hyponatremia occurs in more than 48 hours. Okay. So now let us look at the symptoms of acute hyponatremia. So what are the symptoms of acute hyponatremia? So you can have nausea, you can have hiccups, you can have headache, fatigue, you can have confusion, lethargy, cramps, and very severe hyponatremia can finally result in seizures. So what is the reason for this? Now you know that whenever there is hyponatremia, this is your extracellular compartment, this is your intracellular compartment. So there can be movement of fluid from where? Along the concentration gradient of water, it can move from the extracellular to the intracellular. So if this happens, what happens? This results in your intracellular swelling. This results in your intracellular swelling. Now if there is an intracellular swelling, then what happens? This results in cerebral edema. Okay, this results in cerebral edema. That is the reason why neurological manifestations are a very common manifestation of hyponatremia. Okay, so you can have confusion, you can have lethargy, you can have cramps, seizures, you can have nausea, vomiting, hiccups as premonitory symptoms of hyponatremia. Okay, fine. Now in chronic hyponatremia, how will the patient present? Patient presents predominantly with fatigue. They do not have much of neurological symptoms. Why? Because the brain has had time to adapt for these volume changes. That is the reason why in chronic hyponatremia they will not be that symptomatic, but in acute hyponatremia they will be severely symptomatic. Alright, let's move ahead. So what are the investigations that you want to do in a case of hyponatremia? You want to do serum osmolality? Yes. You want to do a urine osmolality? Yes. You want to do a urine sodium and a serum sodium. Okay. So based on this you can identify whether this is hypovolemic, euvolemic, hypervolemic hyponatremia, and you can find the etiology of hyponatremia as well. Fine. Let us look at the treatment of hyponatremia. So what are the general measures that you have to take? Always identify the underlying cause, right? Always go through the drugs, like I had mentioned. Always go through the drugs which can be implicated in your hyponatremia. Then, if the patient is conscious oriented, right? So somewhere the sodium is between, let's say, 130 to 135, or if it is a chronic hyponatremia, generally the patient may not be of lethargic or confusion or having any nervous system abnormalities, and he may be able to take orally. So if he is able to take orally and you have established the cause of your hyponatremia, you have established the cause of your hyponatremia as a hypovolemic, okay, hypovolemic hyponatremia, and is it because of a poor intake? If it is because of a poor intake, then you go ahead and give them oral salt. But if this is a hypervolemic hyponatremia, like for example, the patient of heart failure or liver failure or chronic renal failure presents to you with hyponatremia, or if you feel that this is an SIAD, right? You feel that this is an SIAD, you have ruled out adrenal insufficiency, you have ruled out hypothyroidism, and you feel that this is an SIAD, then fluid restriction would be the first line treatment for that patient. Okay, so this is about the general measures for the management of hyponatremia. Now let us move on to acute hyponatremia. Acute hyponatremia, I told you, it is very, very dangerous. What happens is that the patient may be confused, alter mental status, so you have to urgently treat these patients, right? So they remain symptomatic and the premonitory symptoms will be nausea, fatigue. Okay, so how do you treat them? What is the fluid of choice or the treatment of choice? The treatment of choice in these situations, you cannot go and give them oral salt, right? They are not in a situation to take orally, right? So then the treatment or the fluid of choice is your 3% NaCl. So if you go back and look at the section, or if you have already gone through the section on IV fluids, you understand that 3% NaCl is a treatment of choice for hyponatremia. So how do you give this? In severe symptomatic hyponatremia, if the sodium levels are less than 125. So in severe symptomatic hyponatremia, when the sodium levels are less than 125, actually the levels do not matter. It depends upon the degree or the speed at which it has reduced. But more often in severe symptomatic hyponatremia, you give them a 100 ml bolus of 3% saline. Now if the sodium has not improved thereafter as well, then you can also give a repeat dose. Okay, so this is as per the latest guidelines, you give them a bolus push because the patient is very, very sick. But always keep in mind that you have to do an hourly sodium monitoring. So after this bolus, is your work done? No, you will have to do an hourly sodium monitoring and continue the 3% NaCl as an infusion. Continue the 3% NaCl as an infusion. Okay. Now, how do you determine the rate of the 3% NaCl infusion? So, how do you determine the rate? Now, let us look at how do you determine the rate. So, target rise. Always remember the target rise in sodium should not be more than 8 to 10 milliequivalents per day. What is the reason for that? Because when you go at a rate of more than 10, what is there a risk of? There is a risk of, or in other words, rapid correction of sodium. Or in other words, rapid correction of sodium is discouraged because of the risk of osmotic demyelination syndrome. Because of the risk of osmotic demyelination syndrome. Okay, so what happens in this osmotic demyelination syndrome? It is also called as rapid pontine myelinolysis. Rapid pontine myelinolysis. Okay, so in this ODS or osmotic demyelination syndrome or rapid pontine myelinolysis, what happens is that, what is the pathology? There is a demyelination in the pons. There is a demyelination in the pons. So when there is a demyelination in the pons, what happens? What happens is that the clinical features is that the patient can have rigidity, the patient can have myoclonus, the patient becomes mute, right? And he can have quadriparesis. Patient will have quadriparesis, right? So rigidity, myoclonus, mute, quadriparesis, right? So this is a completely devastating condition. So rapid correction of sodium at a rate of more than 10 milliequivalents per day if the sodium rises, right? So if your sodium is 120, do you want to make it 135 on the same day? No. Please do not attempt that. The aim will be only to raise it from 120 to maybe 128 or 9. That itself is enough. because you have to prevent the seizures, prevent the complications of hyponatremia, but treatment also can cause a complication which is your ODS, right? So this is a completely devastating condition where the patient is unable to talk, right? He is unable to move. He can have catatonia, he can have myoclonus, he can have rigidity, right? So ODS has to be prevented. That is the reason why you will have to go at a slow rate. The bolus dose initially which you give at your 100 ml bolus dose, that can be administered, but after that you have to do an hourly sodium monitoring and monitor the rise of sodium properly. Okay, fine. Now let us see how do you calculate your sodium deficit and how do you administer this 3% saline. Okay, so let us look at this example where suppose this is a patient where the current sodium levels are 112. Target sodium will be what? Right, it should not be more than 120, right? To be on a safer side, you need to increase it only by 8, right? So 120, this will be your target. Till here clear? So what is the sodium deficit formula? The sodium deficit formula is given by total body water into change in sodium. So how is the total body water calculated? This we have already learned. It is given as 0.6 into 60, that is the weight, and this is the percentage of body water. We have learnt it in your previous section in your basics of fluid and electrolytes, right? Into change in sodium, how much are we aiming? 8, right? So this is 288 milliequivalents. So this is your total sodium deficit, right? 288 milliequivalents for one day. That is for this day at what speed we have to go. Okay, fine. Now, what is the fluid of choice? What is the fluid of choice for treatment? We use 3% NaCl. We have learned from the previous class on your section on the basics of fluid and electrolytes that 1 liter of 3% NaCl has how many milliequivalents of sodium chloride? It has 513 milliequivalents, right? Now to achieve this deficit of 288, how much of 3% NaCl you have to give, right? So you have to give 288 by 513, which is 0.56 liters or 560 ml. It is 560 ml. Okay, so you've understood that. Till here clear? So first step is that you take your target sodium. Patient comes with hyponatremia. Let us say for in this example, the sodium is 112. Your target sodium will be 120. Then you have to calculate your sodium deficit. How do you calculate your sodium deficit? It is given by total body water into change in sodium. How much that you expect. Total body water is given by 0.6, which is your percentage of body water, into your body weight, average of 60 kg, into your change. So that gives us your sodium deficit. We know that 3% NaCl is the fluid of choice. 1 liter has 513 milliequivalents. So your deficit of 280 milliequivalents, how many liters you should use? You should use 560 ml. Now, how do you determine the rate? Now this 560 ml has to go over how much? Over 24 hours. So per hour, what will be the rate? Per hour will be at 560 by 24, which is maybe around 23 cc per hour. Okay, so this is about your calculation for sodium deficit. And how do you determine the rate of the infusate? Okay, it depends upon how much you want to increase the sodium and how much of 3% NaCl you are giving at what rate. Okay, got it till here? So first step is you calculate the sodium deficit. Second step is you decide how much of 3% NaCl you want to give to achieve that sodium deficit, and then you decide the rate per hour. Alright, now let us understand chronic hyponatremia. Let us understand the management of chronic hyponatremia. If the patient is hypovolemic in your chronic hyponatremia, basically this is what? Hyponatremia that has been for more than 48 hours. Okay, so if the patient is hypovolemic, what will you give? You will give IV fluids. If the patient is conscious oriented, please give them oral salt as well, maybe because their intake has been poor. If the patient is hypervolemic, then you have to restrict the fluids. And in fact, in some forms of hypervolemia, like in heart failure, there is dilutional hyponatremia. So you can give them diuretics. Diuretics will remove the water as well, not only the sodium, it removes the water as well, and it can help in the treatment of the hyponatremia in hypervolemic hyponatremia. Then in SIADH, what do you give? You do restriction of fluid. You do restriction of fluid intake and the second line drug will be your Vaptans. The second line drug will be your Vaptans. Okay, fine. So this is about your management of hyponatremia. So what all have we learnt till now? We have learnt about your hyponatremia, approach, SIADH, cerebral salt pasting, and how do you calculate your sodium deficit and how do you manage acute and chronic hyponatremia. Okay. So see you all in the next class where we will be learning about hypernatremia. Thank you.